Hi guys, welcome back to Shira's Farm. Today is going to be our first clinical session and it's going to be all about hypertension. So the first thing that we need to go over is actually the three different types of blood pressure readings that we can get. So that is from a clinic blood pressure, a ambulatory blood pressure and a home blood pressure. Just to let you guys know that sometimes I do pronounce words wrong just because in my head I think they sound like that when they don't, so just bear with me. So the first one is a clinic blood pressure, a clinic environment basically. So that could be from a doctor taking a blood pressure reading, a nurse, a pharmacist, and it's where the patient sometimes gets something called white coat syndrome. So sometimes a patient can feel stressed, not relaxed in that certain environment and not comfortable, and that is where their blood pressure reading actually is higher than normal, and that's what we call a white coat syndrome. This gets the doctor, nurse or pharmacist, etc., trying to actually figure out whether their blood pressure reading is actually that and it tends to look like that, or it's to do with them not feeling comfortable, relaxed and stressed in that environment. Now, the second type of blood pressure reading that you can get is an ambulatory blood pressure. So that is basically a portable device that someone can clip onto their belt, or they can clip onto their waist, or sometimes I think they actually have mini pouches that people can slot into like a bag on their shoulder, and it's basically a cuff around their arm, and that is a 24-hour device. And what happens is that at certain points in the day the cuff will start to tighten and expand around the arm, and that's basically telling the patient that the device is about to take their blood pressure. And the last one that we do have is a home blood pressure reading, and that is basically the devices that you can walk into a pharmacy, buy over the counter, put it on the table, click the button, and it will expand on the arm. That's what we tend to use in a pharmacy setting. The reason why we need to make sure that we understand these three things is because sometimes I've seen it in mocks, and I don't think it came up in my exam, but I did see it in mocks quite a few times, and it'd be like Mrs. X had her blood pressure reading, her ambulatory blood pressure reading or clinic blood pressure reading, and it came up as this. Because for example, clinic blood pressure readings tend to be higher than ambulatory or home devices. So those are the three different types. The next thing that we actually need to go over are the three stages of hypertension: stage 1, stage 2 and stage 3. Now, just before I start talking about the stages of hypertension, I've just done a little mini summary of what I'm about to talk about, so you guys by all means can screenshot this and print it off and then follow what I'm about to say, and hopefully that will make it easier for you to understand. So stage 1 is to do with offering lifestyle advice. So you've got clinic blood pressure and ambulatory blood pressure readings that will define whether someone's under stage 1, stage 2 or stage 3. So if someone is in a stage 1 category, then they will basically have a clinic blood pressure reading of 140/90 or higher, or they will have a ambulatory/home blood pressure reading of approximately 135/85 or higher. Now, whoever gets one of these readings, they will be offered lifestyle advice, but there is one exception. If there is a person who is under the age of 80 years old and has one of these readings, but in addition to this they have one of the following, then you will be giving them treatment. So that is if they have target organ damage. So target organ damage can be something like chronic kidney disease or hypertensive retinopathy, or something like left ventricular hypertrophy, where the ventricles are basically have increased, the left ventricle has increased in size. So those are what the target organ damage is, but in conjunction to this, you've also got things if they've got diabetes, kidney disease, cardiovascular disease, and also if they've got a 10-year cardiovascular risk of greater than or equal to 20%. That figure, 20%, you guys need to make sure you remember, because in the exam they can put you off and they can give you another figure, because a 10-year cardiovascular risk does come up in another topic. I'm pretty sure it's diabetes, and that is a different risk. I'm pretty sure that's 10%. So make sure you know the difference and make sure you learn the figures and don't get mixed up between them. So that is all about stage 1. Then stage 2, the figures that I'm about to state, regardless of whatever age the patient is, you're going to give them treatment. So the clinic blood pressure reading that they would get would be something like 160/100 or higher, or they would have a ambulatory/home blood pressure reading of 150/95 or higher. And then the last one is going to be the stage 3, and that is hypertensive crisis stage. So that is if they have a reading of 180 over 110 or higher. This will require medical care because they can basically get a reduced supply of oxygen to the organs, or they could have cerebral infarction, etc., etc. So you need to get them into immediate hospital care. So now we need to move on to clinical targets. So there are a lot of targets to remember and different categories that differ in blood pressure reading targets. The reason why we need to know this is because you're going to find that in practice there are going to be a lot of patients that are going to come up and ask you, what should my blood pressure reading be at home approximately? And you're going to need it, or preferably you're going to need to know on the top of your head what to tell them. So here are the targets that you guys are going to need to remember for the exam. As you can see, I've sectioned it off for you guys, so hopefully it will be easier for you guys to follow and understand. So first we'll start with under 80s. So the blood pressure reading, the clinic blood pressure reading should be less than 140 over 90. However, for an ambulatory / home blood pressure reading, the target should be less than 135 over 85. So there is also another blood pressure reading which is less than 130 over 80, which is specifically for people who have atherosclerotic, see, those are one of the words that I can't pronounce, atherosclerotic cardiovascular disease, or if someone has diabetes with some sort of kidney disease, cerebrovascular disease, or even like eye disease like retinopathy or something like that. So under 80s, you've got 3 different targets. Over 80, they need to aim for a clinic target of less than 150 over 90. However, that ambulatory / home blood pressure reading should be less than 145 over 85. Then you've got renal disease. So renal disease patients need to aim for a blood pressure reading of less than 140 over 90. But also you can get renal disease patients who have chronic kidney disease and diabetes, who have proteins in their urine, approximately more than 1 gram in their urine in the last 24 hours. With these specific patients, they need to aim for a blood pressure reading of less than 130 over 80. So you've also got diabetes patients. So diabetes patients, they need to aim for a blood pressure reading of less than 140 over 80, but also they're going to be diabetes patients which also have complications. So they have eye complications, cerebrovascular complications, and kidney complications. If they do have that, then their blood pressure reading needs to be lower, so they need to aim for a lower blood pressure reading, which is less than 130 over 80. And last but not least, it's going to be the pregnancy category. You need to aim for a blood pressure reading of less than 150 over 100, so that's specifically for pregnant women who have had chronic hypertension. Then you have got women who have chronic hypertension and they have target organ damage. So remember what I said about target organ damage? It can be something like hypertensive retinopathy, chronic kidney disease, or left ventricular hypertrophy. So those who have chronic hypertension and target organ damage, they should aim for a blood pressure reading of less than 140 over 90. Now we need to move on to the first line, second line treatment, etc. for less than 55 years, more than 55 years, and African Caribbean individuals. First line treatment for less than 55 years old. So for these people, the first line would be ACE/ARB. What tends to happen is that we'll start the patient on an ACE inhibitor, and then sometimes in, I think it's a small population of people, they'll end up developing dry cough. That's because of the way ACE inhibitors work, and they prevent the breakdown of bradykinin, which develops a cough in those individuals. When this happens, we tend to move the patient onto an ARB. However, there are situations where some individuals can't take an ACE inhibitor, nor can they take an ARB. Maybe they're not tolerating it, maybe it's just contraindicated. So what we can actually put them on first line is a beta blocker. Step 1 for more than 55 years old or of African origin is going to be a calcium channel blocker. However, there are some exceptions to this. Calcium channel blockers, if a patient cannot tolerate it, if it's contraindicated, if the patient has edema, if the patient has heart failure, they will not be able to have a calcium channel blocker. So the alternative would be a thiazide-like diuretic. Thiazide-like diuretics, which tend to be used in hypertension, are actually things like indapamide or chlortalidone. So those would be the things that we'd start off with them for step 1. Now moving on to step 2. Step 2 for less than 55 years would be adding on a calcium channel blocker, or if they can't take it for the reasons that we've already spoken about, then we'd move on to a thiazide-like diuretic. Let's say, for example, a patient came in and they were diabetic, and first line we started them off with a beta blocker, and then we've got the step 2 as 2 options to be a calcium channel blocker or thiazide-like diuretic. For someone who's diabetic, we do not want to give them a beta blocker or a thiazide-like diuretic together. That is because both of them cause hyperglycemia. That will not benefit someone who's already diabetic. That will just increase their glucose levels and most likely cause more complications. So that is just something to remember, because in the exam, what tends to happen, and it did happen in my exam, is that they'll give you a whole list of drugs and they'll be like, what is the what do these drugs most likely affect in regards to electrolytes or glucose or things like that. So as long as you know what drugs cause what, you'll be able to answer those types of questions. So moving backwards, so step 2 for less than 55 years would be adding on a calcium channel blocker or a thiazide-like diuretic. Now step 2 for over 55 years would be adding on an ACE inhibitor or an ARB to the calcium channel blocker. So as you can see, there's a pattern. We're just adding on the other alternatives, making combinations. And then step 3 for less than 55, more than 55 and of African origin is going to be ACE/ARB plus calcium channel blocker plus thiazide-like diuretic. We're going to put all those combinations together. The last step is resistant hypertension. So this stage is basically where we've tried quite a few combinations for that specific patient, but however, their blood pressure is not being controlled. So we've got 2 alternatives here. So we can start them off with a low dose spironolactone, but with this we need to be careful of their potassium levels, because with spironolactone it causes hyperkalemia. So we need to basically make sure that their potassium levels are less than 4.5, because then this will basically be sufficient enough for us to start them on spironolactone. Or let's say we've looked at their potassium levels and their potassium levels, they're more than 4.5, then we would want to start them on a high dose thiazide-like diuretic, i.e. indapamide or chlortalidone. So the dose for indapamide that we tend to use is 1.5 to 2.5 milligrams once daily. Chlortalidone would be something along the lines of 12.5 milligrams to 25 milligrams once daily. So that is everything. That is basically standard procedure for what goes on when in regards to what medication to give to someone in regards to their age and African Caribbean origin, but also at the same time, now that we're on hypertension and the stages, we might as well talk about diabetics and hypertension and pregnancy and hypertension. So for any diabetic patient, regardless of what age they are, the first line that you're going to give them will be an ACE inhibitor. You need to make sure that you remember this, because this has come up in questions before. The reason why we give this to them is because diabetic patients, what tends to happen is that they further down the line, they might end up having complications with their kidneys. ACE inhibitors long term are actually renoprotective, so they help to protect the function of the kidneys. Let's say if we have a diabetic patient who is also Afro-Caribbean, then we're going to give them 2 drugs as first line. Now, because they're diabetic, we said we're going to give them ACE inhibitor. But because they're also of Afro-Caribbean origin, we're going to also give them a calcium channel blocker. So an ACE inhibitor and a calcium channel blocker as a combination will be first line for someone who is diabetic and also of Afro-Caribbean origin. There is also pregnancy. We've got 3 drugs that tend to be used in pregnancy. That is either labetalol, methyl-dopa, or modified release nifedipine. So there's just a few things you need to remember about these drugs. There's not a lot that you need to remember. Labetalol ends with ol, so obviously it's a beta blocker. Biggest thing with beta blockers is that it's contraindicated in asthmatics. And also with labetalol, it is hepatotoxic. Moving on to methyl-dopa, the one specific thing that you need to remember with methyl dopa is that all women, if they've been using it during pregnancy, they only have a 2-day period of when they need to stop it after birth. So let's say someone's given birth, after that they have 2 days to stop taking the drug. And modified release nifedipine, probably the only thing that you need to remember with them is that they don't tend to be used. I'm pretty sure it's unlicensed as well in pregnancy, but it's still an alternative. For pregnancy, that is what you're going to take if someone is pregnant. You've got those options of drugs. However, if someone is considering to get pregnant, so they've got hypertension and they think they're going to have a very high chance of becoming pregnant, then the first line treatment would be a calcium channel blocker. So this is for someone who has not gotten pregnant yet. This is for someone who has hypertension and they think that there's a very high chance of them becoming pregnant. So you're going to start them on a calcium channel blocker. So that is everything for the stages, first line, second line treatment for those different types of categories. And now we're going to move on to the drugs. Now it's going to be about ACE inhibitors, beta blockers and calcium channel blockers. So ACE inhibitors and ARBs, so we've got ramipril, captopril, lisinopril, perindopril. We said for ACE inhibitors they cause dry cough specifically, persistent dry cough, and if that is the case then most likely we'll move the patient onto an ARB, which is for example losartan, candesartan, etc. A few things about maybe 2 of the ACE inhibitors is for example perindopril. So that specifically is only that ACE inhibitor, you would actually take it 30 to 60 minutes before food. Quite a lot of patients I realise actually aren't being told that. So during MURs and things like that, it'd be great to make sure that they're taking at that specific time. And also captopril is the only ACE inhibitor that is taken twice daily. All ACE inhibitors tend to be taken once daily. When someone is first started on an ACE inhibitor, the advice that you'd give them is to take the ACE inhibitor for the first day at night time because it can cause postural hypotension. After that they can take it once they get up, but as long as they take the first dose at night time then they're good to go. Now in regards to the side effect, ACE inhibitors do cause hyperkalemia, especially in patients who have renal impairment and who have diabetes. So remember, ACE inhibitors equals hyperkalemia. In addition to that, ACE inhibitors do cause hypoglycemia as well. So those are the 3 most important things to remember. So persistent dry cough, hyperkalemia, especially if they've got renal impairment and diabetes or diabetes, and hypoglycemia. So long term, I think I've probably touched on this, is that they are renoprotective. However, short term they can cause acute kidney injury. So you might have come across the acronym DAMN, so DAMN. So you've got D for diuretics, A for ACE/ARBs, M for metformin, and N for NSAIDs. So all these affect the kidney function, the kidney structure, and they can cause temporary damage to the kidney. You look at creatininuria, creatinine clearance of a patient, and you can define from that the patient has got kidney injury, then you would temporarily stop those medications. Then you've got something called the EGFR. So EGFR is basically like a measurement, a reading that basically tells us how the kidneys are. So if they're good or bad. So the lower the EGFR, the worse the kidneys are. If you guys remember in like first year, for example, you've got the afferent arteriole that tends to be dilated, and then you've got the glomerulus, and then you've got the efferent arteriole, which tends to be quite thin. So having the afferent as dilated and the efferent as quite thin, that gives us a pressure gradient which helps for the kidneys to work properly and for them to filter correctly. However, what ACE inhibitors tend to do is that they tend to reduce the EGFR, because what they end up doing is actually dilating the efferent arteriole. And that happens, the pressure gradient ends up basically getting ruined, so the kidneys aren't working properly. So that's just another thing for you guys to remember. ACE inhibitors should also be avoided in pregnant women. In regards to creatinine clearance, so it's not just for ramipril that I'm about to speak about, but there are a few other drugs in the BNF that specifically state if the creatinine clearance is a specific value, then you can only give a maximum amount of milligrams for a specific medication. Now, you will need to know some of these off by heart. I'll do my best to bring them up in the videos to come, and specifically what I'm about to say. So for example, for ramipril, if the creatinine clearance for a specific patient is 30 to 60 ml per minute, then you can only give them 5 milligrams maximum daily. If the creatinine clearance is less than 30 milliliters per minute, then you can only give them 1.25 milligrams daily. You need to make sure you remember these values because they do come up in exams, and you will need to make sure you know them off by heart. Now, just very, very quickly about ARBs. ARBs basically cause hypotension. They also cause hyperkalemia, and they also cause dizziness, for example. There's not a lot of things that you need to know about ARBs apart from just knowing a few examples like losartan, candesartan, etc. And then we're moving on to the odd drugs. So you've got, in the hypertension section, you've got a category called centrally acting antihypertensives and vasodilation antihypertensives. So the central acting ones are things like methyl-dopa, clonidine and moxonidine, and then the vasodilation ones are hydralazine and minoxidil. You don't really need to know a lot about them, but I can go through a few things. So clonidine, maybe the best thing to know is that it can be used in migraines and flushes, and also it shouldn't be abruptly withdrawn because it can cause rebound hypertension, severe rebound hypertension. And then also for the vasodilation antihypertensives, minoxidil and hydralazine, they are both used for resistant hypertension, and a side effect for both of them is fluid retention and tachycardia. Now moving on to beta blockers. So the first thing about beta blockers are the contraindications that you're going to need to know off by heart, because in the paper they can give you a list of medications that a patient's taking, then it can give you a list of conditions that they also have, and they might ask you which one of these medications does the patient need to stop taking. 5 contraindications that you need to learn off by heart in regards to beta blockers. So the first one is if someone is asthmatic. So that is 100% contraindicated, with one exception, but we will talk about that in a moment. The second one, if someone has peripheral vascular disease, they cannot take beta blockers. If someone has worsening unstable heart failure / uncontrolled heart failure, they cannot take beta blockers. If someone has a 2nd / 3rd degree heart block, they cannot take beta blockers. And also if someone has severe bradycardia and hypotension, they cannot take beta blockers. Those are the contraindications that you're going to need to know. Different categories of beta blockers. So during pre-reg, me and my friends came across quite a few acronyms that we learned off by heart in order to remember these specific categories. So the first one is, if you guys can see it, forget about that ring light, is ICE-PACO. So you've got pindolol, acebutolol, celiprolol and oxprenolol. So ICE-PACO, remember this acronym. So ICE, remember in a way to do with the cold. So these specific medications, they have got less coldness of extremities, so like tingling, numbness, coldness in the fingertips, as well as less bradycardia. Now the next category is water cans. So you've got celiprolol, atenolol, nadolol and sotalol. So this one is to do with water solubility. So these are water soluble medications, so they are less likely to cross the blood-brain barrier, meaning a patient is less likely to experience hallucinations, nightmares, and also they are less likely to have sleep disturbances. So make sure you remember that. And also with these specific medications, they are renally cleared. So in someone who has got renal impairment, you need to make sure that you reduce the dose of those 4 medications. Okay, so the next one is Be a Man. So you've got bisoprolol, acebutolol, metoprolol, atenolol and nebevolol. So Be a Man is to do with asthmatics. So remember when I was like, there is an exception in regards to the contraindication of beta blockers with asthmatic. If someone can't take a specific beta blocker because of their asthma, there are cardio-selective beta blockers, i.e. this category, be a man, which you can use for people who have their asthma completely under controlled. However, these will have to be initialized by a specialist so that it can be monitored. So you can, in specific circumstances, give beta blockers to asthmatics as long as their asthma is well controlled. Next category is vacant. So bisoprolol, atenolol, celiprolol and nadolol. So these specific ones, if you remember the little o there, these ones can only, actually not only, but these ones tend to be given once daily, so the O, once daily, because they are long acting. However, I have seen prescriptions that say bisoprolol to be given twice daily, but then again, just so that you're aware, they do tend to be given once daily, specifically those for the side effect. The first side effect is that beta blockers can cause hyperglycemia, which we have spoken about in regards to beta blockers and thiazide-like diuretics, but they can also cause hypoglycemia. That is because beta blockers affect the metabolism of carbohydrate. They cause both hypoglycemia and hyperglycemia, and at the same time mask the symptoms of hypoglycemia. So someone might be having an hypoglycemic attack. However, because the side effects of beta blockers resemble the symptoms of a hypoglycemic attack, they might not know that they've got that attack. So that is something else to be aware of. In conjunction to this, they can cause bradycardia and hypotension. But remember, the first category that we spoke about, the ice PACO, they cause less bradycardia. Now, we've already spoken about one sort of interaction in regards to beta blockers and thiazide-like diuretics, but there's also another one that you need to be aware of, which are beta blockers and verapamil. So putting them together can also, not putting them together, using those two drugs together, they can both precipitate heart failure. So that is something that you also need to be aware of. Finally, we're going to move on to calcium channel blockers. So you've got two categories of calcium channel blockers. You've got dihydropyridines and non-dihydropyridines. So firstly, we're going to start talking about the dihydropyridine calcium channel blockers. So those are things like felodipine, amlodipine, and nifedipine. The main thing that you need to know about these drugs are the specific side effects. So you've got three main side effects: ankle swelling, flushing, and also headaches. So the flushing and headaches tend to go after a couple of weeks of taking the medication, whereas the ankle swelling can stay. If someone comes into the pharmacy, actually you'll get this quite a lot. I've seen it in community quite a few times. Patients have come in and they've been like, my ankle has started to swell up. The main question you need to ask them is if they're on any blood pressure medications. As soon as they say something like amlodipine, felodipine, etc., then you know it's most likely to do with that medication. So if they do have something like that, the next step would be for them to be referred to the doctor so that they can be put on another medication. Moving on to the non-dihydropyridines, so the rate limiting calcium channel blockers, verapamil or diltiazem. So the two most important things about verapamil and diltiazem are that verapamil causes constipation, and diltiazem, any strength above 60 milligrams needs to be maintained on a specific brand. Make sure you remember this because this has come up in mock exams. This specific category, it needs to be avoided in heart failure. Now, that is the majority of hypertension. That's practically all the most important things that you need to make sure you remember. If you do have any questions in regards to anything that I have spoken about in this video, please do leave it down below. Make sure you share this video with anyone who started to go over the content for the exam, and I will see you guys very soon.